All right. Well, good morning, everyone. Welcome to Geriatric Grand Rounds. A few announcements before we get started this morning. So next Grand Rounds is March 3rd, and our speaker is Dr. Dan Savin, and he's going to be talking about refugee health. Next Journal Club is March 10th, and the presenter is Dr. Dan Matlock. Following today's Grand Rounds, you will receive an email with a link to the presentation, and also will be included a link to an online evaluation. So if you could please take a couple minutes to fill that out, we would really appreciate that. So I'm really excited to introduce our speaker for this morning, Dr. Peter Pressman. Dr. Pressman is a cognitive and behavioral neurologist. He joined the Rocky Mountain Alzheimer's Disease Research Center in 2016, came to Colorado after training and working for 4 years at the University of San Francisco's Memory and Aging Center. Before that, he completed his residency training at Northwestern Memorial Hospital in Chicago. He attended medical school at Oregon Health Science University, where he previously worked in the Alzheimer's Disease Center. Dr. Pressman was drawn to Colorado for many reasons, including the exciting opportunity to help build a new dementia center in the Rocky Mountain region. He runs the communication and speech analysis in the neurocognitive disorders lab, has focused on the neuroscience of what people say and how they say it. He also runs a clinical trial of sargramostim in Alzheimer's disease and is very involved in outreach and engagement, particularly of traditionally underserved populations. So we're really excited to have Dr. Pressman here today to talk about advances in Alzheimer's therapeutics.
Thank you very much for having me. So I was just saying, one of the things that I'm most interested in here is hearing from everybody else. And so I really welcome your comments throughout this. I understand that those will be added into the comments section, and we'll be discussing questions as at the end of this. I have to say, I just got over finally a course of COVID that my son brought home. So please forgive me if I'm a little bit scattered through this. Fortunately, when it comes to Alzheimer's therapeutics, or rather fortunately for me this morning, I would normally say there's not much to be said, in that I'm not sure that we have come very far, despite all the noise that has been made in the last few years around aducanumab. I'd like to use this really as an opportunity to make sure that after all of the whirlwind of 2020 and 2021, we're able to touch base and make sure that we know where we stand now. So just before I get going, a little bit of any potential conflict of interest. I have been PI on a couple of industry trials, aducanumab itself during its phase 3, and I'm still sub-I on a extension of that trial here. I also was involved with an industry trial for frontotemporal dementia, and I'm currently PI on 2 NIH-funded trials of GM-CSF, that's sargramostim or leucine. So today I'm going to be making sure that we're kind of on the same page regarding terminology and concepts in Alzheimer's disease. There's a lot of variation in how people conceptualize this disease, and so I just want to make sure you know where I'm coming from. We'll review current treatments and therapeutic approaches, and then we'll go back a little bit and review the recent history, the tortured tale of aducanumab. And then try to move towards the future, including both how we might begin to screen for appropriate use of Alzheimer's therapeutics, as well as current clinical trials in development. So starting with just a perspective on Alzheimer's disease now. So usually when I say Alzheimer's disease, I am referring to a histopathological diagnosis. This usually signifies sheets of amyloid and tangles of tau, with which this audience is very familiar. But also a reminder that this is a very complicated disease, and the story goes well beyond amyloid and tau. Our group is particularly interested in the role of inflammation, but there are multiple other therapeutic approaches that could be pursued and are being pursued now in other clinical trials. This is related to, but I think distinct from, the syndromic diagnosis of Alzheimer's disease, meaning the collection of symptoms that we usually call Alzheimer's disease. Someone usually over the age of 65 with slowly progressive memory loss. So this is a increasingly obligatory slide just to remind everybody of how this concept has been evolving over the past approaching couple of decades, where we see the histopathological changes associated with Alzheimer's changing well before the clinical symptoms of Alzheimer's disease, which you see there in green. And if you look at other biomarker related changes, such as amyloid in purple, you'll notice that by the time you start to first have symptoms of Alzheimer's disease, and certainly by the time those have reached the dementia level of severity, it looks like amyloid has already hit peak level badness based off CSF studies. This is, I'm only including to remind everybody that there are multiple other things out there in Alzheimer's disease beyond amyloid and tau. So there are various aspects of inflammation you could be focusing on. You could be focusing on synaptic loss. You could be focusing on tau hyperphosphorylation. You could be focusing on aspects of cell death or blood-brain barrier integrity. So let's talk a little bit, just reviewing what is currently available. I think that we already do more in the field of Alzheimer's disease than we often give ourselves credit for. So I think an underappreciated fact is that the age-adjusted incidence of Alzheimer's and related disorders has been falling according to large retrospective studies, not just the Framingham Heart Study, but other places as well. These really come out of so-called first world countries, where we are seeing good healthcare, which I think is the cause of this. So if you are a 70-year-old now, you have less chances of having a dementia than you would have, say, a couple of decades ago. Of course, as the population overall gets older, we do still expect dementia to remain a major problem. And I hope that many of you are familiar with this Lancet article that suggests that many cases of dementia may be preventable just by lifestyle adjustments throughout the entire course of life. So by attending to things like physical activity, social isolation, smoking, hearing loss, we may be able to prevent 40% or more cases of dementia. And this model didn't even really include things like diet or sleep, which I also think are important. Of course, our patients don't just want to hear about lifestyle modifications. They really want to hear about, well, okay, what medications can you give me? The first medication is often forgotten, and for good reasons probably, and that was Tacrin, approved in 1993. This helped with symptoms by boosting levels of acetylcholine in the brain, and led to better tolerated medications that are more widely used, like Aricept, donepezil, galantamine, and rivastigmine. And until just last year, the last drug that we saw approved to treat Alzheimer's was memantine, Namenda, working on a different neurochemical. And then we have been continuing to try over all these years to find something else that would work. So you see a review here of 235 investigational agents at various stages of development, all of which has been quite costly, about 42.5 billion, as you can see there. Now, again, up until last year, and perhaps now, most Alzheimer's drugs enhance how neurons communicate with each other. So the medications like Aricept, Razodime, Exelon really work by boosting acetylcholine. Namenda works on glutamate. And this, I think, led and has contributed to a really frustrating industry purporting to do, I think, more for Alzheimer's than we can, while not giving sufficient credit for what we are already doing. I am mostly wanting to draw your attention to a quote in the upper middle there. I always find it interesting when the medical or scientific industry shout about the danger or quack science of holistic or alternative treatments while outright admitting there's nothing they can do to help patients. Doctors uniformly insist that nothing can stop or slow Alzheimer's disease. I think that's not true. I don't say that and have given good evidence to the contrary. I try and lead with a hopeful message, in part because I feel this is a very vulnerable population, just because this is such a devastating disease and it does compromise your ability to make good decisions. So what do we do now? Besides those lifestyle modifications, we are also ruling out treatable causes of cognitive impairment, insomnia, sleep apnea, depression, anxiety, and so on. As I'm sure many people on this call are very used to doing. I think that we offer non-pharmacological guidance. The folks in geriatrics are especially good at helping guide conversations around advanced care planning. And we offer what modest pharmacological benefits we can. So where does aducanumab then begin to fit into this story? As an aside, I primarily study facial expression and paralinguistic communication, and this guy's smile looks a little bit nervous to me, and I understand when it comes to aducanumab. This has been a very controversial topic. And so I am well aware that things I say may irritate people in the audience, and I actually kind of welcome that, in that I want to have a conversation, not just about aducanumab, but Alzheimer's therapy in general and where we're going with this. So just a rapid review of aducanumab and how it works. Aducanumab binds to amyloid and helps it clear. I think that is pretty unequivocal, actually, in the studies that have been done. It does so with some considerable risk of side effect, relatively high amount of amyloid-related imaging abnormalities, or ARIA, which we think likely represents brain swelling. Most of that is asymptomatic. It's only caught on MRI, but not all of it is asymptomatic. Sometimes it is associated with things such as seizures, for example. These two large studies, Emerge and Engage, studied a very select group of people with relatively mild Alzheimer's disease and few medical comorbidities. Aducanumab was given monthly, with the strength increased to 10 mg per kg over the first 6 months. And here's where we're going to try to refresh ourselves, as if 2020 and 2021 weren't confusing enough with the pandemic. Those of us in the field of Alzheimer's were also staring down the barrel of a potential biological therapeutic, something that might actually be disease modifying, and trying to figure out how we were going to try to accommodate it, or whether we even should. The first time aducanumab crossed my radar was in a Nature article in 2016. And I remember my father actually reaching out to me and asking if he should be investing heavily in Biogen, and I suggested not yet. There are two then large clinical trials that built on top of that very promising early data. And both were initially stopped, as so many clinical trials have been in Alzheimer's, for lack of efficacy in a futility analysis. However, late in 2019, they did another analysis on these data, focusing just on those who had mild disease, and who particularly those who were ApoE4 positive, and seemed to find signs of modest benefit. Based off of that analysis, which was only true in one study, they proceeded to the FDA. A very early preliminary review was positive, but then the expert panel, as many of you no doubt remember, was very negative. Out of 11 experts, only one didn't say no, and they were equivocal. Nevertheless, we began to see aducanumab proceed through an alternative route, which was focused just on that amyloid removal. And so ultimately, the FDA did approve it through that alternative route based off the putative benefits of amyloid removal. And Biogen immediately gave it a pretty extravagant price tag of $56,000 a year, which was more recently downgraded to a still pretty unreasonable price of over $28,000 a year. And this is without considering the need for extra monitoring. 3 panel members, all of whom were and are very highly regarded in the field, resigned in protest. A petition was circled to appeal to CMS not to approve coverage of aducanumab. I should say I have since seen letters being written to CMS to appeal. Several professional associations, including Geriatrics, said we shouldn't be using this outside of trials. There have been allegations of improper contacts between Biogen and the FDA. Major hospitals have refused to keep it on formulary. It's still not on formulary at the university or the VA. I still haven't seen those results in a major journal discussing aducanumab's supposed benefit. I would be very interested if anybody else can bring those to light. And as I alluded to earlier, those of us who are invited to talk about this become increasingly a little anxious about doing so. CMS recently said that they would only approve this within the confines of another clinical trial. And we have not seen much excitement in terms of insurance coverage. So last year, arguments were made in the New England Journal for and against aducanumab. I'm going to try to summarize a few of those here. So for its approval is that in that post hoc analysis, 4 clinical endpoints were gently positive. There was a relationship between the amount of exposure and the response. Some say, others have called that analysis into question as well. Many people still strongly adhere to the idea that treating amyloid should really treat this disease. And so that the decision to use it as a proxy for disease modification was reasonable. There is a kind of philosophical argument of, yes, we recognize this study is imperfect, but surely it's better than where we were, which is with nothing. And there's a lot of appeals to pathos with a lot of patients who really have a desperate need for a therapy. And highlighting that this is an important first step, that at least it's a sign of movement, and maybe this will foster further research. You can see some of my comments there in the parentheses. Against the approval, there are concerns about some irregularities in this approval process. It's unusual for a panel of experts such as these to just kind of be ignored. There are very real concerns about the risk to benefit here. Any benefit, even in the study that suggested that it existed, was quite modest. We have yet to have great peer review. There is also a concern about, okay, with this $28,000 a year price tag, who is going to be able to get this? Who's going to be able to afford it? And certainly without insurance, the only people I know of who have been getting this are people who can afford to pay for it out of pocket. There is mentioned concern about, so why are we now accepting that amyloid is a reasonable surrogate? You'll recall that Jack curve that I showed at the beginning. Amyloid is basically maxed out by the time we start seeing symptoms. It looks like most of the opportunity to do damage is kind of potentially done by that point. Are we sure that that's the right target? And if it is, why have so many other trials failed to meet this endpoint? A large meta-analysis done last year and published in July clustered all those amyloid-centric trials together and looked at them. And it did suggest perhaps a modest statistical benefit, but probably not much clinical benefit. And so the closing argument within the NEJM debate was that perhaps rather than spending funds on this drug or even this line of thinking, maybe we should be focusing on other therapeutic routes. And I would say yes, and maybe we should also be spending this money on better care of dementia now and preventing dementia, especially given the increasing evidence for lifestyle modification in dementia prevention. So after all of that, where are we now? I think that we can say for aducanumab that it is a landmark, even if it still doesn't quite let us know what we should do with it. Many providers are willing to prescribe this, and some patients seem to be willing, especially if they can afford it. Even the initial approval by the FDA did require a prolonged phase 4 study to show signs of its efficacy. And now with CMS, it sounds like they're really thinking another phase 3. I haven't heard much detail about either of those. I'm going to talk a little bit more about that and where it stands, but it's another, we don't really know that much at this stage. However, I do think that it is a landmark. I do think that we need to be prepared for the advent of biological therapeutics. And if nothing else, all of this should spark conversation and thought about that. At this point, every time I talk about the pros and cons with aducanumab with my patients so that they can make a well-informed decision, they have uniformly decided against taking the drug. So what now, or I think more realistically, what down the line should we consider as a good process for deciding who could get an Alzheimer's biological therapeutic? Some have suggested just falling back on the criteria of the clinical trials to help determine what use is appropriate. And I'm not going to relay all of these. I'm just listing them really to say it's pretty restrictive. Highlights include the requirement of a positive biomarker to prove that this is in fact Alzheimer's, as the risk of misdiagnosis seems higher than many of us had originally assumed. Early on in this process, I was personally pretty stressed out about the possibility of a viable Alzheimer's biological therapeutic coming to market. And I was trying to figure out whether or not we would be drowned by demand. I thought we probably would be. And so I wanted to try to propose a processing pipeline for how these people could be screened and how we could select who would be appropriate. This is only a proposal. The basic idea is that if somebody was over the age of 55 and concerned about the possibility of underlying Alzheimer's, their concerns for their cognitive impairment would be validated first with a simple screen that could be done even in the offices of busy family medicine practitioners. Only if that was positive, then would we proceed with the basic workup for cognitive impairment and manage other known risks. So we cannot forget about all the other things that cause cognitive impairment, particularly at mild stages, depression, anxiety, and so on. And we need to make sure that those are adequately treated. If there was no improvement and all the labs for causes of reversible dementia were still normal, then we would want a dedicated referral, perhaps even just a quick e-consult or telemedicine, depending on the amount of demand. And based off that, we could make a decision on whether or not biomarkers were indicated. Those biomarkers usually are a lumbar puncture at this point. Blood tests are reportedly becoming available, but I think most people still really question their reliability. PET scans seem pretty reliable, but are expensive and not covered by insurance currently. If biomarkers were indicated, then I think we would start having a dedicated specialist referral process. That's not to, we can't forget about then the need for subsequent monitoring, given the risk of ARIA associated with a lot of these agents. So we would need repeated MRIs just to confirm safety through the disease course, and close monitoring of cognitive benefit as well. As mentioned, a recent study suggests that alone is probably at least $6,000 extra a year for patients on these medications. So where do we go from here? Perhaps it should be concerning. A group has routinely gone over all of the clinical trials in the pipeline annually. I haven't seen it yet this year, and I'm used to seeing it every January, which I hope doesn't argue that aducanumab is distracting us from other more viable approaches. As of a year ago, this is kind of an overview of how we were doing in the processing pipeline. So you can see where different trials were in different phases, how many had actually reached regulatory approval. And you can see how we are focusing not just on amyloid and tau, but on circuits, synapses, immunity, and others. So most of the agents here, you can see, are targeting disease modification. And there's still some focus on reducing symptoms. Hang on, sorry. There we are. So in 2021, we were looking at 126 different agents, mostly in phase 2 of the process. I want to suggest an interesting trend here. So if we go backwards from phase 3 towards phase 1, you can see that, again, the majority here is disease modifying. And you see that in phase 3, about 29% of the cases were focused on amyloid. And then as we move towards an earlier stage of development, we see a smaller proportion, but a higher number, absolute number, focused on amyloid. And then, sorry, no graphic for this, but on a review of available phase 1 clinical trials, only saw one anti-amyloid. So it feels like the field overall is trying to get away from the amyloid that aducanumab is targeting. This just summarizes some of what I was just describing there in graphic format. And I want to highlight some of these other potential targets: epigenetic, growth factors, vasculature, proteostasis. I remember going to the Alzheimer's Association International Conference in 2019 when these studies had been stopped. And I was actually very encouraged to see how people were looking away from an amyloid-centric view of the disease and exploring other possibilities. It felt much more creative an environment. That said, I do think we're going to see more anti-amyloid applications. I think we're going to see more and probably, quote, better drugs come forward with fewer reported side effects and better marketing strategies than what we saw from Biogen. So just sharing what we're doing here in neurology. So Dr. Victoria Pellick has stepped up to run the extended phase 3, those who were part of the original eMERGE trial before it was stopped. We had 5 such participants, only 1 still remains, as well as potentially a phase 4, though with CMS's decision, I wouldn't be that surprised to see that slide back to more of another phase 3. Dr. Holden, who runs our memory clinic, made a lot of plans in case of an quote aducanumab surge, but we never ended up seeing that, which all of us, I think, in neurology were very happy about. I've continued efforts in outreach, trying to make sure that if aducanumab or any other biological therapeutic were to become available, that we would have a plan for appropriate triage. Other things that are ongoing in our group, I am running a clinical trial of sargramostim, that is leucine, to explore other possible treatment approaches in Alzheimer's. We have ongoing observational studies, not just in Alzheimer's disease, but also other neurodegenerative conditions like frontotemporal dementia, Lewy body. We're continuing to explore ways to improve care just through building a patient care database. And we continue to reach out to traditionally underserved populations. So given the focus of this talk, let me tell you a little bit more about leucine or sargramostim. Most of this work has been done by Dr. Huntington Potter, who runs the Alzheimer's and Cognition Center. And this work goes back some ways, even before he joined us in Colorado and was doing work in Florida. It came from the question of, why do people with rheumatoid arthritis seem to be at a lower risk overall from developing Alzheimer's disease? So Hunt took a very kind of big approach to this question and just looked at all the different ways that people with rheumatoid arthritis differed from those without, and ended up with a particularly good candidate in GM-CSF, sargramostim leucine. He then moved on to mouse models, demonstrating that GM-CSF reduced amyloid deposition, and I would argue more importantly, seemed to reverse memory deficits in Alzheimer's mice when tasked with a water maze. Other studies had shown that GM-CSF seemed to improve cognition in cancer patients who were suffering from, quote, chemobrain. And there were suggestions of improved function in neurodegenerative conditions like Parkinson's disease as well. So with that, we moved forward at this center with a very small phase 2A trial. And that trial having been completed, are now getting started on a larger phase 2 trial. As a reminder, this is really just to show that GM-CSF is safe in Alzheimer's disease. We hope for more signs of efficacy. There were suggestions in that phase 2A that the mini-mental actually improved in the group who had GM-CSF. But we'd like to replicate that and potentially move forward into a phase 3 to shore up those results further. Little bit more about that trial now. So this is the former trial that was done. So with the improvement in the mini-mental store, some potential reduction in neuronal damage and blood biomarkers. And the current trial, I'm just showing a little bit about the things that we are measuring. Now I realize this must be very, very small on your screens. I'm chuckling to imagine over 30 people all leaning in. If I still maintain your attention that much. The basics are that we're gathering medical history, Montreal Cognitive Assessment, and basic vitals, screening for anxiety and depression, just to get people in the screen for this study. We'll be getting an MRI scan, and we are confirming a diagnosis of Alzheimer's with lumbar puncture for all study participants. There is an optional PET scan as well. Over the course of 6 months, then people will be getting very regular injections of sargramostim with regular assessments, primarily of safety, making sure there's no injection site reactions or other signs of ill effect, but checking in periodically on a clinical dementia rating scale, as well as the mini-mental and other assessments of verbal fluency, neuropsych inventory, ADAS-Cog, and so on. So hopefully, as you have received copies of this, those who have questions about that particular experimental design will be able to refer to that. And I'm happy to take some questions right now. Thank you as well for bearing with my ongoing COVID spaciness. Let me switch to the chat here.
Thanks, Peter. There's a couple questions in the Q&A if you want to address those.
Oh, I'm looking.
Do you want me to read them?
Would you mind? I don't know if I can see them from here. Let me see.
Sure.
Oh, wait, I got it.
You got it? Okay.
Wait, no, I don't.
So the first question came in, I think when you were going through the screening process that had been proposed for aducanumab.
Yes.
And the question was if you could comment on what's the consensus for which biomarkers are used for screening purposes.
Good question. I don't know that there is a consensus. Right now, I think that if a viable biological therapeutic was available immediately, the best candidate would be a lumbar puncture. That's because of availability. It's because I know that insurance will often cover for that. There are obvious concerns about doing a large number of lumbar punctures as well, which is why we try and move it far back on the screening process. As part of Dr. Holden's efforts to prepare for what was described as a possible aducanumab surge, we were in conversations with others in neurology to figure out, okay, if we suddenly needed a whole bunch of LPs performed, how would we go about that? More pragmatically, I also feel that if such a biological therapeutic were to come forward, I think that PET scans would also likely become offered, and during that time frame that it will take to develop such a drug, I think we're going to see more progress made in serum biomarkers as well. By the time serum biomarkers become available, I think that the main risk will be people just ordering those serum biomarkers and then saying, okay, it's Alzheimer's, go get this biological therapeutic, without appropriately screening for other things which may very likely be contributing to someone's cognitive impairment. Remember, those biomarkers can change years before they may ever contribute to somebody's cognition or lack thereof. And so just because that biomarker is positive doesn't mean there's not another primary cause of somebody's cognitive deficit. So I just hope that doesn't get lost in the shuffle.
Another question kind of also about biomarkers. Could you say more about the lower than expected finding of biomarkers in persons thought to have
This is a story which has been also evolving since biomarkers have become available, and comes in part from the world of clinical trials. So in a study of bapineuzumab, for example, when they looked at people who were and weren't ApoE4 positive, they found that up to 35% of those who were presumed to have Alzheimer's disease didn't. And if you're enrolled in a clinical trial and that clinical trial is not working, well, maybe a major cause for it not working is that a high percentage of folks never actually had the disease. In a similar way, comparing to even more, quote, gold standard of autopsy, studies in 2016 or so suggested a misdiagnosis rate in a more kind of typical population of closer to 10 to 20% of misdiagnosis, which is still considerable given the small effect that we're looking for, say, in clinical trials. And when you're delivering a diagnosis as serious as Alzheimer's, I don't think it needs to be emphasized that we want to be right. We don't want to be delivering an errant diagnosis. So I think that the risks, though, are especially high in certain subgroups. So we don't get biomarkers on everybody clinically. If you are over the age of 65 and have a classic progression of memory predominant symptoms, you don't need biomarkers unless maybe you need to confirm it for something like aducanumab. I will only reach for these under set circumstances, such as when someone's under the age of 65, or there's something unusual in their presentation, or there's a competing diagnosis, and if I think it's going to impact the patient's management or planning. So that was a little long-winded, sorry.
Thank you. Another question, actually a couple questions about sargramostim. One question was, could you discuss the general inclusion criteria for that study so that we may refer patients if we think they are appropriate? And then what side effects are you seeing with that treatment?
Sure. So let me answer those in reverse. Relatively few side effects. Now, sargramostim works. It's an older agent, so some on the call may not recall it, but it's primarily used to stimulate bone marrow in people who have become depleted, usually by chemotherapeutics. And so you can't even really call it a side effect if it ends up boosting your white count. That's actually been an important part of the therapeutic design, or this trial design, because we need to follow the labs and there's a risk of unblinding. So we had to kind of go through some convolutions to figure out how to maintain the blind while still monitoring everybody. There are possibilities of swelling. There's always a possibility of injection site reaction and so on. And a big question for me regarding the safety is that sargramostim hasn't usually been used for prolonged periods of time, say regularly over 6 months. We're working with hematology to ensure that it remains safe, and so that we can get consult if we need to. But we want to keep a close eye on anything that should come up over that period of time. As far as the inclusion criteria, let me make sure that I send something that is more comprehensive, if I may. So I'll just send a quick study description. Our DSMB has only now, actually just within the last week, given its blessing to proceed with recruitment. Now that we have that, let me make sure that I can send everybody here a more complete study description. But contraindications, for example, based off what I just told you, would be known hematologic malignancy, where we could be making that worse. If there is a known history of rheumatoid arthritis, that would also be something of a contraindication, since we might be provoking that. And we'll also want to exclude, of course, other known causes of cognitive impairment. So if somebody has been doing methamphetamine, for example, we recently had to let them know that they would not be a good candidate for our study. But I'll go ahead and make sure that I send out more complete description.
That would be great. Thank you. Another question about biomarkers.
Yep.
Do we know the sensitivity and specificity of A beta and tau in spinal fluid and pathologically confirmed Alzheimer's disease? And does that vary by age?
Yeah, reports vary. And it also, so I'm glad that you specified versus autopsy, because I think another question is, even with autopsy, does this mean that you are symptomatic or that the amyloid and tau are the cause of your symptoms? Compared to autopsy, the sensitivity and specificities have been reported to be quite good. The cited sensitivity in the panel that we use is over 95%, with less specificity, close to 70%, though other studies have suggested that the specificity may also be over 90–95% as well. The other question is, so let's say that you do have amyloid and tau in your brain. Does that matter? We know, based off, for example, the NUNS study, that people have died with their brains riddled with amyloid and tau, and that they were cognitively intact, perhaps due to ample cognitive reserve. And so I mention this because of the question about age. I think that these results need to be interpreted with great caution if you are over a certain age. As, for example, over the age of 75, upwards of 30–35% of people who are healthy will have amyloid and tau present in their brain. And that doesn't mean that they will ever develop symptoms.
Thank you. Just looking for any other questions.
Am I allowed to ask questions?
Yeah.
Okay. Thank you all. I am curious on a number of fronts about the work that is being done in geriatrics, both regarding clinical trials and well, a lot of other things too. We'll try and stay focused. So regarding potential screening, I'm curious if others want to share their thoughts about it. I wanted to emphasize Tacrin in this presentation because I hope that Tacrin is a kind of useful allegory for what aducanumab could be. Not a great drug in and of itself, but a sign of possible things to come. And with that in mind, I do anticipate a time, perhaps not too far from now, where we will have biological therapeutics. My question then is, how do you envision your role? How do you, where do you picture yourself? How will you manage this? I expect everybody to have different answers. And there's disagreement in the Department of Neurology on this as well. I just would really value your perspective. And again, this isn't about aducanumab per se. I think my lack of enthusiasm for this drug is, I can't I can't pretend impartiality. But when something comes up, how will we handle that?
Great discussion topic, and it's so hard to do this in this format, I think. But one comment is because geriatrics sees patients over the age of 75 and average kind of mid 80s, we may not be the right clinic. And I'll just say, in my limited experience seeing patients and being involved in research, often what happens is we're looking for patients to participate in clinical trials, but so often the patients in our clinic do not qualify because of not just age, but usually they have many comorbidities, they are frail, they are just not able to participate, they're not healthy enough to participate in so many of the trials in the first place. And I think that's what I've tended to see a lot. So that is often a barrier.
Would you use age over 75 as a sole criterion for not giving a biological therapeutic? Certainly there's going to be a higher risk of comorbidities. You're going to see higher risk of heart disease and stroke and all of those things, which I would say were exclusionary. But
I think I would say, this is just my perspective, is it's less age than it is overall health, functional status, life expectancy that tends to disqualify our patients most of the time, not age alone.
Have people gotten many questions about aducanumab or clinical trials generally?
I have not had anyone ask me about it. I'm not in clinic. I have a fairly small patient panel. I haven't heard of us getting a lot of questions about it. I'd be curious to see if other providers who are on have different experiences or have been asked about it.
It mostly comes from patients' children. That makes sense.
Yeah.
Yeah, I have been comforted by the lack of interest. I'm usually pretty skeptical of how the media covers Alzheimer's. I say that as somebody who used to do a lot of writing for the general public. I think that the right message has been conveyed here. And I think, well, for better and worse, there is an increasing skepticism of how scientific enterprise moves forward now, which may have been validated by what we saw happen with aducanumab. So the same skepticism that may make people say vaccine hesitant may have worked in our favor when it came to the aducanumab story.
Yeah, another comment, just 0 questions about it from patients or families from another provider. So.
Yeah. So I think really the question is just not, it's a familiar position. If I had to sum up advances in Alzheimer's therapeutics in very few words, I could probably do so in 2, not much. And I might be able to say a little bit more about hope. I think, as I said before, that we already do more for people with cognitive impairment than is widely appreciated. And I do think that we are going to continue to see more movement in Alzheimer's biotherapeutics. so long as we don't allow ourselves to be blinded by the perhaps misleading signal of the amyloid therapies, I really think that we're better off putting our money and effort elsewhere. I see a comment here. Many patients want to know whether they will experience, will my mom recognize me again outcomes. I emphasize the answer to that question, which I think is no, in my conversations about aducanumab. I think if there's a signal, then we have to accept that that signal is quite modest, and like other therapies should be considered something that slows a trajectory, does not stop or reverse this disease.
Great. Well, we're at time, so we'll wrap things up. Thank you so much for presenting, even while you're feeling under the weather. We hope you feel better soon, and thanks for ending on a hopeful note. And this was a great presentation and discussion, so thank you so much.
Thank you all again for having me, and thanks for sharing your perspectives as well. The last year has been kind of dizzying, and it's nice to talk with others to help figure out where we currently stand.
Thanks, everyone.